هاي اهلا وسهلا. السلام عليكم. النهارده هنتكلم على محاضرة الكوليرا في السيلبس بتاع الانفكشس موديول. انا دكتور وليد اللقاني، lecturer of tropical medicine department في جامعة الاسكندرية قسم tropical وconsultant of hepatology و GI endoscopy. هنتكلم النهارده على محاضرة الكوليرا. Firstly, we have as a sort of an epidemiological studies the number of cholera cases reported by the WHO in the last few years. During 2017 was 1,200,000 cases were notified from 34 countries, and that's why nowadays we are making or taking this. It has been present as a sort of pandemic or an epidemic in the 50s or in the mid of the last century in 1950s. Nowadays it's re-emerging disease again, and the WHO has said that in 2017 there was 1,200,000 cases were notified, and including 5,654 deaths. Okay, so what's the causative organism of this cholera? It's the Vibrio cholera. The Vibrio cholera, actually it's a short gram-negative curved rod, and it have a very rapid darting movement. And just remember this darting movement, because during the diagnosis we will have something regarding this darting movement. We're gonna say it later. The antigenic structure, actually it's having a flagellar H antigen, which is heat lipide, and somatic O lipopolysaccharide. It's now divided into O1 and O139 the O1 serotype is further subdivided into biotype or biovar, classican, and Eltor. Biovar according to the biological reactions. The O1, which is the classical, and Eltor are further subdivided according to the epidemiological studies into Inaba, Ugawa, and Hiko-Jima. The Vibrio cholera and its biovar Eltor are the causative agent of epidemic and endemic cholera. Recently, the serogroup O139 was also found responsible for several epidemics. What's the biochemical reactions regarding the cholera? Actually, it has oxidase positive. It grows on the thiosulfate citrate bile salt sucrose agar in an alkaline medium, which is 8.6 pH, making yellowish colonies. And from here we can also this is a nucleus to make the diagnosis furtherly in the lecture. The reservoir, actually the human or the mankind is the main and the only reservoir for cholera. What's the mode of transmission? Actually it's fecal-oral transmission. So the common vehicle is transmission, the ingestion of contaminated food, water and drinks by the feces of infected individual. Who's much more susceptible? Actually the patients who are having gastric achlorohydra, increased risk of illness, and breastfed infants are protected. So that's why the patients who are having atrophic gastritis, who are having on chronic PPIs, proton pump inhibitors, having achlorohydria or hypochlorohydria are much more susceptible rather than normal individuals. The pathogenesis or the pathology. The main pathology is due to the virulence or the virulence of the Vibrio cholera. It attains its virulence from attachment to the microvilli on the brush border of the small intestine, and you know that the small intestine is having a large surface area for more and more absorption of fluids. So when you break this, or when you make a sort of an interference with the absorption of the absorptive power of the small intestine and the microvilli, this may lead to secretory diarrhea, which is so-called watery diarrhea, and it's actually severe and heavy, till maybe it may lead to dehydration. It attached themselves from the microvilli of the brush border of the epithelial cells, where they multiply and liberate heat labile, cholera enterotoxin, which is responsible for the manifestations of cholera. The Vibrio cholera enterotoxin actually is formed from two subunits, subunit A and subunit B. And the GM1, which is the gangliocyte mucosal 1, it's a receptor. Here we can find that it's a receptor for the B subunit. So the GM1 receptors, it's found the brush border of the intestinal cells, and it's a receptor, it acts as a receptor for the B subunit of the enterocyte of the cholera enterotoxin. Actually, the B subunit, when it make a bond with a GM1 receptor, this may facilitate the A subunit to enter inside, making a complex with the adenyl cyclase, and this may activate the cyclic AMP, and the cyclic AMP, when it's activated, this may lead to increase in the secretory secretion of fluids, and thereby loss of water and electrolytes, and this is the main pathogenesis and the main pathology of the cholera. Okay. So from here we can estimate the clinical picture of a cholera and the virulence of this bacteria. The incubation period actually is short incubation period from 1 to 3 days. The clinical presentation, it varies from a mild, uncomplicated diarrhea to a fulminant and lethal disease. The manifestations, as we said, it's loss of isotonic watery stool, rich in sodium, chloride, bicarb, potassium. The virulence of this and the morbidity and high mortality in the cholera diarrhea is the abrupt onset of painless watery diarrhea up to the severity that it may lead to dehydration. The intense thirst, oliguria, muscle cramps, weakness, and mild loss of tissue turgor with the sunken eyes and wrinkles of skin on fingers, and these are actually the manifestations of dehydration. So the main clinical presentation is severe, abrupt, painless, watery diarrhea up to the level of dehydration. And the manifestations of dehydration, as we said, the intense thirst, the dry tongue, oliguria, electrolyte imbalance in the form of muscle cramps, weakness, marked loss of tissue turgor, sunken eyes. And here we come to the complications of cholera. Actually, most of them are due to the dehydration, which are hypovolemia, hemoconcentration, oliguria, and anuria, potassium depletion and electrolyte imbalance, severe metabolic acidosis, which may lead to renal failure. What's the diagnosis of such case? Actually, the laboratory diagnosis, the stool cholera patient contain large number of vibrios, 108 per milli. So it's copious inside the stool of the patient, of the diseased patient, and this make the diagnosis easy. The stool should be collected from the administration, before the administration of antibiotics, of course, as not to make any sort of a biasing effect of the antibiotic on the bacteria. Actually, we take a fecal swab, mainly obtained from a rectal swab. Okay, and just note that the collection of the swab is not from the pan of the feces, because it may be there is a sort of a contamination or risk of contamination or other antiseptics or something, and this may lead to biasing effect also on the diagnosis of the cholera. We have three impacts, or three categories, or three items regarding the diagnosis for this rectal swab, the feces as a specimen, which is the microscopy, culture, and molecular biology. Firstly, the microscopy, which is the rapid diagnosis, and it's actually used during epidemics just as a rapid test using the dark field microscopy and immobilization under dark field microscopy. Actually, in the first of this talk, we have told you that it has a characteristic motility, which is the darting movement or darting mobility of the Vibrio cholera, and from here we can see that immobilization actually under the dark field microscopy demonstrates the darting movement, and by putting sort of an anti-serum on this, there is a sort of immobility, and here you are specifying that you are diagnosed with Vibrio cholera. Moreover, as a rapid test, the fluorescent antibody technique, which is examined by ultraviolet microscopy. Also, as we said, from the criteria of the Vibrio cholera, it can be cultured on an alkaline medium, which is the TCBS, cultured incubated in 37 degrees overnight, and then making yellowish colonies. From these yellowish colonies, you're taking specimens or making an oxidase reaction test positive, and here also it's diagnosing the Vibrio cholera. Finally, the molecular methods, which is the PCR or the DNA probing for detecting the toxigenic Vibrio cholera. Here we come to the prevention, the general preventive measures, that the sanitation, and you should wash your hands, and so these are the general preventive measures. Apply also general preventive measures for a foodborne illness. Okay, and there are specific measures and guidelines for food handling and food handlers, and how we can make good use of food, of handling the food. Okay. Finally, the specific measures are the immunization, which is the oral cholera vaccine. Oral cholera vaccine, and there are actually two types of vaccines. Both of them are killed whole cell. Either it's monovalent with the B subunit of cholera toxin, or killed modified bivalent, which is the O1 and O39 vaccine without the B subunit. So again, we are having two types of oral cholera vaccine. Either of them are killed. Either killed whole cell monovalent with recombinant B subunit, or killed modified bivalent without attachment to the B subunit. Firstly, the monovalent O1, it's given as a 2 doses with a 1 to 6 weeks apart, but children from 2 to 5 years are having one more dose, so they are having 3 doses, 1 to 6 weeks apart. The killed modified oral whole cell bivalent O1 and O39 without the B subunit, the age recommended is more than 2 years. It's given 2 doses, 2 weeks apart. 1 booster dose is recommended 2 years later. How can you control this disease, or how can you control this epidemic or pandemic or endemic illness. It doesn't make any endemic. No, how can you control if the cholera makes an epidemic? For example, you have to report any suspected case to the local health authority. Secondly, isolation and the beginning of treatment. Hospitalization with the enteric precautions is desirable for severely ill patients. However, strict isolation is not necessary. Less severe can be managed in an outpatient clinic or outpatient basis. The treatment is a fluid and electrolyte replacement, either oral or parenteral. Moreover, the antimicrobial therapy. So the basis of treatment of cholera is, firstly, you have to replenish, you have to replace this dehydrated patient with fluids and electrolytes, because actually this is the main virulent factor for cholera is dehydration, is severe painless watery diarrhea, severe loss of water and electrolytes. So you have to replace this by either fluid and electrolyte replacement, and moreover you have to target the bacteria by certain antimicrobials. Okay, we'll discuss in the next slide. So you're giving the patient, either he's conscious or unconscious, okay, either by ORS, the oral rehydration, or just drink water freely, okay, in the patient who is conscious and he can drink by his own, and there isn't any fear from either, for example, aspiration or something, and he's giving this oral drink for 75 milli per kilogram body weight over 4 hours. And to your own knowledge, actually speaking, the daily requirements or the requirements for a normal patient for drinking water normally without any sort of dehydration is about 25 milli per kilogram body weight. So here you are making a sort of increase over a short period of time, trying to replace the fluid and electrolytes for this patient who's unable to drink and who's comatose, and there is a fear from aspiration, for example. Give plenty of intravenous or parenteral fluids in the form of either normal saline, ringers, any sort of a replacement to the fluid and electrolytes. The infusion should be 1 to 2 milli per kilogram per minute until the blood pressure became normal again and the pulse is regaining its strength. Amount of fluid replaced should be equal to the measured stool volumes. Solid food should be given after the vomitus stops and appetite gets normal. Okay, how adequate is the regaining the hydration? Actually is in the form of the blood pressure, regaining the blood pressure again, the hypovolemic shock, state of hypovolemia, state of hypotension, it's regained again. The pulse, this thready pulse, this weak pulse, it's regaining its strength. Moreover, the skin turgor, it's regaining its elasticity, and the urine output is regained again. These are the signs of regaining the hydration of the body. Moreover, the electrolyte imbalance, you're gonna correct the electrolyte imbalance, like the hypokalemia, or giving doses of either in the form of ORS or intravenous potassium chloride. The antimicrobial therapy, that's the other entity targeting the bacteria itself. Mainly, as you know, it's one of the subdivisions of tetracyclines, like the doxycycline. But actually, the doxycycline is not preferred, or it's contraindicated in children and pregnant. So a single dose of azithromycin, 1 gram per orally, is given to pregnant or children. Maybe trimethoprim sulfamethoxazole or ciprofloxacin but also ciprofloxacin is not indicated, or it's not preferred in pregnant and children. Finally, as a sort of a control measures, you have to make a sort of a disinfection for the feces and vomitus of the patients, of course, and a good sewage system as not to make any contamination of the drinking water from the patients of cholera, especially in the epidemics. And here we come to the end of this lecture. Thank you so much for your kind attendance, and it was a pleasure to be with you. Thank you so much.